Good evening, everyone. I am Arpita from the IGCP group, and it is my pleasure to welcome you all to this very special panel discussion on immunizing our future, pediatric immunology in a changing world, organized to mark World Immunization Week. We are truly to have honored to have with us an eminent panel of experts with us today. First, I would like to introduce Dr. P.S. Narang sir, who is moderating today's session. Sir is a Senior Director and Head of the Department of Pediatrics at Max Super Specialty Hospital, Shalimar Bagh, Delhi. Next, we have with us Dr. Narendra K. Mehra sir, who is former Dean and National Chair of All India Institute of Medical Sciences, New Delhi, Vice President of International Affairs, Indian National Science Academy, New Delhi. Next, we have with us Dr. Gulshan Sidhu ma'am. She is the head of the Department of Internal Medicine at Sidhu Hospital, Ludhiana. So this was a very brief about them. If I start reading about them, it will take the whole night to cover three of their bio. So we look forward to a thought-provoking and insightful discussion as we delve into the evolving landscape of pediatric immunology, the challenges we face, and the implications shaping the future of immunization. Thank you once again, everyone, for joining. And now, without further ado, I will request Dr. P.S. Narendra to take over the session. Over to you, sir.
Good evening, my
Good evening.
audience, the doctors and my two experts, Dr. Narendra Mehra, who has a vast experience in the field of immunology, Dr. Gursaran Sidhu, who is a physician and now changing with vaccination platform. She has a major role to increase the adult vaccination. Sir, with due respect to everyone, vaccinology is considered the field of a pediatrician. They think that the child starts with the vaccination, and by the time the child is 2-year old, 5-year old, the parents assume the vaccination has completed. So today at this platform, I want to tell all my audience, including doctors, that vaccination beyond infancy and childhood. And what's the importance? In fact, the first vaccination chart, which is given to people in abroad countries, especially as UK, it shows vaccination chart from birth till 85 years, and especially above 50 years with comorbidity and above 60, the role of vaccination becomes important because adults and people with a compromised immunity also gets certain diseases which needs to be prevented. And as a most important role as a doctors, I would say the doctors, especially I worked in bone marrow units abroad, and working in the bone marrow units abroad, you not only have to see that you are vaccinated, you also have to see that your immune titer are so good that you are neither going to give infection to the patient when they are immunocompromised, or not you're going to get infection from the patient in case you are not properly immunized. And we all know the very good cocoon theory that if you have people of immunocompromised at home, that all the persons in the family needs to take vaccination and needs to protect themselves with physical as well as good barrier so that the immunocompromised person at home doesn't get the disease. Well, this much to start with, but where the vaccination has started? Smallpox vaccination was perhaps the one, and the observation was that the people who get cowpox, they don't get smallpox. And one of the scientists from UK observed that the girls where the cowpox was quite prominent, the girls are beautiful, whereas the girls in area where they get smallpox, they get marks on their faces. So what they did is very crude way of taking the fluid out of the one of the lesions of the cowpox, inject into the body, and by uh, destabilizing with the heat or just reducing the intensity by heat and gave and developed the first vaccine. But vaccine, when it comes, doesn't get accepted by people easily because people are worried about the side effects of vaccine. But today we are come to the era where we have developed vaccine which are quite good, safe, and are tested in the lines of proper research. Sir, immunological memory is something which we need to understand. When you get the infection for the first time, your body develops the innate immunity, and then the adaptive immunity comes with the memory cells, with the T and the B cells, which I think Dr. Narendra will be very well to explain that because he has worked in the field of immunology. So, Dr. Narendra, I want you to explain to our audience what are the immunological memory, what are the primary and the secondary immune responses we get, and how the persons are going to benefit from this. And over to you, Dr. Narendra.
Thank you very much. At the very beginning, I would like to thank the IJCP for giving me this opportunity to speak to this very learned audience. And I want to start where you left, Dr. Narang. I mean, you gave a very good example of the smallpox. The smallpox vaccine was the first one to be developed, and that was way back in 1796. And this was
Yeah,
by this guy called Edward Jenner. And
yes,
even today, we call Jenner as the father of immunology because he created the first very vaccine, the smallpox vaccine. He was an Englishman and a doctor and a scientist who developed that actually 1796. What he did was he noticed the people who develop cowpox is of course a very mild form of disease, that they were also immune to smallpox. So there is that
yeah,
kind of a cross-reactive immunity there. And he then inoculated a young boy with the cowpox to give him immunity to smallpox. And Jenner's experiments actually opened the way for the discovery, I would say, of the immune system as such. He's therefore considered as the foundation of immunology. His work is said to have saved many, many lives. I want to give you one other scientist who really played a very important role. And I think the audience should know about the contributions of Paul Ehrlich. Paul Ehrlich was again a great scientist who developed the side chain theory, which described how cells recognize pathogens and toxins. And he came up with this idea of that the serum of these people would be able to sort of take care of the toxins. The third important scientist who actually got the Nobel Prize in 1901 was actually Emil von Behring. He's a German scientist. And so these people really were the pioneers right from day one. Now, about the primary immune response and the secondary immune response, and that is the basis for vaccination as well. There are two things very important in the immune system. One is the specificity, and the other is the memory there. We are all born with lymphocytes. Lymphocytes are considered to be our immunocompetent cells. There was a time, in fact, when I started, I was in Amritsar Medical College. I came to AIMS. In AIMS in 1970, in our library, there was a book called The Lymphocytes by this uh, British scientist called Yoffe, and the book was all talking about lymphocytes. And that time the electron microscope was not there, scanning microscope was not there, so we only could see under the light microscope. And he described in the book somewhere lymphocyte as an end cell, because a small lymphocyte to him looked like under the microscope is a round cell full of nucleus over there. There are very few, if at all, cytoplasmic organelle. And he thought that if the cell has no mitochondria, or very few of them, this cell will have no function. And today we know that we are here because the lymphocytes were there. Lymphocytes are our really the immune competent cells. These are the cells that we need for conferring immunity to us. Now, when you get exposed to a pathogen, a foreign antigen, which could be a bacteria, the viruses, or the parasites, fungi, and I, of course, specialized in transplant immunology. If you give a mismatched organ transplant over there, it is recognized by the immune system as foreign. So the concept of self and non-self. The immune system, the lymphocyte has that ability to recognize this is something non-self. I must react to this. So the body mounts an immune response, and we call it as the primary immune response. But the primary immune response takes a little longer time because it takes time for the body to garner its resources, its soldiers. So, there are lymphocytes also have now various types of them. One of the types is called the cytotoxic T cells, which will then go and kill the foreign antigen. Is called also the CD8 positive cytotoxic T cell. It takes time for it to come. So it will take about 5 to 7 days, or maybe sometimes 10 days, for the primary immune response to generate. But the body has already developed this memory now. There are all kinds of memory cells formed. So memory is not only in the brain cells, but memory is much more in the lymphocytes. So if this cell for the second time encounters the same antigen, same structure, the structural configuration is the same. Now it mounts what is called a secondary immune response, and which will take much lesser time, and the response will be much vigorous. If the primary immune response was that much low, the secondary immune response will be about 4 to 5 times higher in terms of the vigorous immune response. The idea is, of course, over there is to make sure that the foreign antigen, which the body has now recognized as non-self, is eliminated. But then there are other systems as well, because the body cannot just keep on mounting a very vigorous immune response, which will actually sometimes become deleterious to the human system. After all, we're looking for immune response for health, and so there are checkpoint inhibitors over there, and we will talk about it as we go into the seminar. But this is in general the primary and the secondary immune response. So specificity that particular antigen that the body has seen for the first time, and second is the memory. These are two hallmarks of the immune cells.
Very good, very elaborate description. Sir, organogenesis begins at 3 weeks of fetus. Conception and the organogenesis begin at 3 weeks, completes at 8 weeks.
Yeah.
Even at 3 weeks, the granular macrophage pluripotent erythroid could be distinguished, and these are the first body's immune response. At 11 weeks, the thymus in the spleen develops, and at 12 to 19 weeks, the fetus is fully capable of a good innate immunity. But, sir, continuing with the question, how does the maturation of the immune system differ between neonates, infants, and older children? Especially the neonates gets lot of passive antibodies from the mother. And one of my favorite dialogue is, whatever diseases the mother has faced in her lifetime and whatever vaccination the pregnant woman has taken before her pregnancy, the memory of those antibodies goes into the cell are enough to protect the child before his own system becomes active. So these are the kind of things which we experience. But sir, maturation of the immune system between neonate, infant, and older children, how does it differ?
Yeah, I think that's a very, very important point. But before I come to that, I think the audience must understand that there are two major branches of the immune system: the innate immune system, as you talked about, and the adaptive immune system. I think these two. There's also a third one that we call about passive immune system. That the mother passes on the antibodies to the child. So the innate immune response is imminent. It comes immediately. It takes very little time. And the cells involved over there are neutrophils, monocytes, macrophages, and dendritic cells, which all of them interact with then the adaptive immune system. Adaptive immune system is the one that we develop as we grow old. So actually, there are several genes that are involved in the innate and the adaptive immune responses. And these genes are of great importance for sustaining life in a hostile environment. Yet the immune system is relatively immature at birth and has to evolve during a life of exposure to multiple foreign challenges. For example, we and through childhood, through adult age, through the young age, in the mature adulthood, and as we go into the old age, the immune system starts to decline. And there comes a very important role of how do this immune system be developed? From where? So this mother cell, what we call the parent cell, or all these lymphocytes is in the bone marrow. Of course, in the prenatal life, it is in the yolk sac. The yolk sac is taken over by the liver, and as the child is born, it is the bone marrow. So the stem cell from bone marrow, and even today, as you know, and you have worked in the hematopoietic stem cell unit over there, we still use bone marrow as the source of our stem cells, although we can also take from the cord blood or other sources over there. So the stem cells, the lymphocyte parent cell from the marrow has to go through the thymus gland. So thymus gland is right inside the chest over there in the upper part of the chest, and it is very well developed in the young age in the children. But as we age, it involutes because there is no need for that by that time. So if you would look into my system or maybe yours, the thymus gland has already gone down. We call this thymus gland as the university. This thymus gland teaches the cells which move from bone marrow through the thymus, they have to acquire certain education. They get educated in the thymus, educated to react to the foreign pathogens over there. And as they come into the thymus gland, they are what we call double negative. But once they leave the thymus gland, they acquire those surface markers like the CD4, which is a helper T cell, and a CD8, which is a cytotoxic T cell or a killer cell. So these are the two main types of cells. And since the audience is common people, I'm not going to go into details of other cells. There are, of course, many other, but we call T regulatory cells and other cells over there. But let's focus our attention to these three or four categories of cells which are very important from immune system point of view. The CD4 positive T cells, which are called the helper T cells, they develop in the thymus gland. And the CD8 T cells, which also develop in the thymus gland, and they leave the thymus gland and they populate the peripheral lymphoid organs like spleen, the lymph node, the Peyer's patches, and the peripheral blood. So they move around. And the our cytotoxic cells or the killer cells move around like soldiers. They go around over there looking for anything that is foreign. But the antigen, the foreign antigen, the other property of the immune system is a very snobbish cell, the CD4 T cell. It doesn't recognize the antigen directly if it is a virus or the bacterial derived antigens over there. Is like I'll give an example and I give it to I teach my students that way. It's like a formal guest that comes to your house. You give that guest a cup of coffee or a tea, but you give it in a mug and not on a formal saucer and a plate, a saucer and a cup. Immune system is very formal. It wants the foreign antigen to be presented to it in a very formal way. And this presentation requires what we call MHC, the major histocompatibility complex, or the HLA system there. If HLA was not there in humans, the immune system loses its ability to recognize anything as foreign there. So this makes the system even more complicated over there. But what I'm saying is that the innate immune response is imminent. It is very active at birth over there. But as we grow, it sort of wanes. So from uh, as from im, from the immune system being immature at birth has to evolve during a life of exposure to multiple foreign antigens. As we sort of grow, we sort of get exposed to foreign antigens through childhood via young and mature adulthood, and then they decline. In utero, and you talked about the 15 weeks, actually, the fetal environment demands that the immune system remains tolerant to maternal alloantigens, particularly ones which are non-inherited. After all, the child is growing in utero. The child has got half the quota of genes from the father's side, and ideally it should react to that, but that's not done. So there is some amount of tolerance over there to maternal alloantigens, but after birth, this sudden enormous exposure to environmental antigens, many of them derived from the intestinal commensal bacteria, calls for a rapid change to make the
Yeah.
system grow from innate to the adaptive immune system.
Very good, sir.
And
I mean,
yeah.
I'm impressed with your knowledge.
No, no. What I'm saying is that, and in preterm infants or the newborn infants, for example, the immune system is very immature, and you have to be very careful. And you have seen, therefore, and you would see in your own practice as well, the number of neutrophils actually go down in them, in the preterm child. So these children are more prone to infections and all that, because of, and there is also a reduced frequency of pulmonary macrophages in premature and in infants over there, and the adult levels of these cells are reached only after birth. So there's a lot of difference between neonatal immunity and as you grow in the young child to the adulthood.
Yes, sir. I think you have elaborated the thing so well. In fact, pregnancy is the first transplant which is only successful because of the T helper cells, because 50% of the genetic material comes from the father and 50 from mother, and the womb doesn't recognize that father's material so easily, but the T cells helper are there. And sir, the word vaccine has come from the word vaka, which is a cow, and that's a cowpox vaccine. And the scientists like Louis Pasteur, Sabine, they all developed, and the word vaccine invented from there. I'm moving to Gursharan. Gursharan, there is a lot to do with the vaccine, and it's very good that today most of our states have got good national immunization schedule in which a lot of vaccine are given, and some other states are giving the primary DPT, some other states have added pneumococcal, and some other states have added rota, and so on. The things are improving, and minimum that we are seeing is a much better scenario today. Then how do you decide that the additional vaccine beyond the national immunization schedule for your patient? I mean, patient has received basic DPT, pneumococcal, but there are so many vaccines which are there, which are become, which are part and parcel of many immunization schedule world over, but it's not in our country. So how do you tell the parents about this additional vaccine? Are they necessary, or they need to be given, and what kind of precaution the patient needs to take?
Right, sir. As you've already described that pediatric vaccination is different in different parts of the states, but we definitely had guidelines for the Indian schedule of the vaccinations, and many times all are not available in the government sector, the expensive ones like vaccination for chickenpox and all, but definitely they are there are guidelines and they are available in the private setups. So availability could be one of the issues, but all vaccinations need to be given to one and all, at least because pediatrics of course is the building blocks, and then gradually as soon as the adults come, we go to the adult vaccination as well. But like all vaccinations need to be given first of all, like if chickenpox vaccination is not available in the government sector, but it needs to be given anyhow. And many times we receive children who are of Indian parents born abroad and they visit India. And I think BCG vaccination is very, very important in those, because BCG is not given in US or Canada or in other parts of the world as well, because they come to India and they are going to repeatedly keep coming to India or countries like Southeast Asian countries. So they need to be given BCG vaccination, apart from, of course, the other vaccination schedules. And patients who are traveling, who are at risk, the children who are at risk, uh, yellow fever vaccination, Japanese encephalitis vaccinations, they are also very important. And sometimes, MMR we are giving at 1 year of age. And sometimes there is already there is an exodus of the disease, and these vaccines can be slightly preponed as well, and then the second dose can be given later. So mumps, because of lots of people are getting mumps, there are chances of getting before you child getting the disease before the child gets vaccinated. So these vaccinations can be given prematurely from what they were scheduled to. So and like hepatitis A vaccination,
Yeah.
is in the schedule, but since it's the government sector is not giving it, it is a expensive vaccination. So the chances of hepatitis A are relatively much compared to the, because of the good hygiene and sanitation and all. So as such, the incidence has decreased. But if a particular area where you see that hepatitis A is coming from that area, then at least the others must be vaccinated. They must surely be vaccinated. So
Yes.
that's about it. And hepatitis B also vaccinations, if it has not been done prior, then of course it needs to be done.
Yeah, very right, Gursharanji, that when the patient comes, beside the sickness, we need to see the development of the child, we need to see the immunization, and immunization we have to plan according to the area they are moving, where they may have more diseases. Hepatitis A is shifting epidemiology. It used to be a disease with very young. Now with improved hygiene and improved hygiene plus in many number of people getting new toilets in India, this disease is becoming more and more in adolescent and adults, and where they have more complications. So we need to cover. Never say these additional vaccine as optional, because all vaccine preventable diseases where you can, like influenza, they are important. They are important with quite a few comorbidities. They are important even in children below the age of 5 years. They were very important, like the COVID vaccine when it came, because we all saw that more cases of pneumococcal. So the pneumococcal vaccine for with comorbidity, pneumococcal vaccine for above 50, above 60, herpes vaccine for above 65, and these are all the things which are coming. Especially when Dr. Narendra talked about the premature babies. The premature babies have a very premature system of their immunity, because most of the antibodies get transferred to the baby in the third trimester from the mother. So they lack with those antibodies, plus their immune system is also premature. So we need to protect them with all this, and
We need to
especially
protect the babies who are born prematurely, and not counting the chronological age of the baby. We just need to vaccinate them
absolutely.
with the time of their real birth. So we go the
Yes,
same way.
absolutely.
So
Absolutely.
unless the baby is like very small in weight, less than 2 kilograms, she is born to a Hep B mother who is positive with HBs AG or an envelope antigen positive. So these babies need to be given hepatitis B immunoglobulins within 12 hours of their birth, and then of course to be continued with the regular vaccinations. So,
Especially for hepatitis B, you have really uh, given a very good insight, because either the mother need to be screened for hepatitis B, otherwise hepatitis B vaccination is given at birth within the 48 hours of the birth, because the hepatitis B has two kind of transmission. One is a vertical transmission from mother to the baby if mother is positive, and the other is later in life if they are using contaminated needles or coming in contact with hepatitis B positive subjects. So hepatitis B is best to be given right at birth, and BCG to be given best in the right at birth, and polio drops. And the success of the vaccination is in terms that we have completely eradicated smallpox. We are at the verge of completely eradicating polio as well. And the number of the infections have come down. So these are all the things which have been a success of the vaccination. Gursaran, one more question to you, that lot of time that you come parents come across, they don't have their immunization card, they have not completed their immunization, they may be migrant, they may be refugees, or they have not taken any vaccination and they are more than 1 or 2 years. And this especially happened during COVID, because during COVID almost for 1 to 2 years our whole vaccination program failed because nobody came out of the houses to take the vaccination. So, how do you take those children for vaccination, and what do you use as a method to
Yeah.
complete their vaccination?
Right, sir. As in medical history, history is very, very important if it is given properly. So, a detailed history kind of a thing, a mother will definitely give. The child was born in the hospital, which hospital, and the child was born at home. Was he given vaccination there or not? And if you think yes, the mother says I took the child at 6 weeks and then at 8 weeks or then 14, at proper 6 months of age, and I got him vaccinated from a proper center, then we will exactly know which vaccinations have probably been given to the child. And then if there is no proper history and the mother cannot explain to you, or the mother is not around, or there is somebody else who brought the baby and the history is not possible, then we treat the child as unvaccinated and start right together. At whatever age the child comes to us, we will be treating him for DPT, for IPV, that five vaccines which we give, then hip titer. We should be giving even at 5, whatever age the child comes to us, we will be treating that child as unvaccinated. And if the history is there, if the mother is able to say okay, he's received vaccination till 6 months of age, and then we continue from where we think the vaccination has been left.
Definitely, IAP has made a good catch up schedule for most of the ages, and giving 1 or 2 doses extra if we can't get the proper history does not matter. It only boosts the immunity, because all the vaccination we know that after giving the primary vaccination, boosters are required, and these boosters are very, very important to build up the immunity. And especially if you can't find the proper uh, vaccination history, then giving additional dose of a pneumococcal, additional dose of a MMR is probably going to help. But there are lots of time worry from the parents that my children will get any side effect from that. That needs to be addressed. A child who's growing well and will never have any problem with 1 or 2 doses if are given in the benefit of the child's health. But there are
Absolutely.
situations, where uh, some immunocompromised patients come, and there are types in which uh, we don't know the child is getting frequent infection, whether he has got any immunity related problem. Dr. Narendra, uh, I want you to elaborate on that. How should uh, we go about diagnosing children with the immune problem? Whether there is any role of the next generation sequencing for the diagnosing of pediatric immunological diseases, or any more you can do about such cases to diagnose, and generally when do you suspect this kind of disorder in the population?
Thank you very much. And I think there's just one more point that we didn't highlight as much, and you were talking about the timing of the vaccination. That's very, very important. And we highlighted the point that our baby's immune system is not fully developed at birth. While they are born, the mother's antibodies last in your body for weeks or maybe for months, because
Yeah,
the mother passes on. That is called the passive immunization. The mother passes on through the placental route the IgG antibodies, and these IgG antibodies would wane in about 2 to 3 months time. Similarly, the breastfeeding, actually the very important role of breastfeeding, because the IgA antibodies come from that. So I think the mothers who are, or the young women who are in the audience, they must understand the very important role of breast milk for at least 6 months of life, if not more, because that gives the passive immunization. That's the time when the newborn's immune system is still growing. And of course, once the newborn comes into contact with the outside world and all that, here comes also the role of some other factors as well, which uh, influence the immunity. One is, of course, nutrition there. Nutrition plays a very important role. The proper nutrition supports the immune development in toddlers and in infants there. The second, of course, as I keep saying, the exposure to pathogens. And I want to give you an example here of what we call hygiene hypothesis. In Scandinavia, the infection rate is very low. Therefore, the autoimmunities are very high in that. And we've seen around the world. That's the hygiene hypothesis. The more the hygiene and super hygiene, where where the body has not been exposed to the pathogens, your immune system has not grown to its full spectrum over there. And that is why, when COVID came, and I used to write very frequently for Hindustan Times for, the sort of educational lectures and all that, on COVID immunity and the vaccination there, because my children actually encouraged me. They said, "You have been writing all those scientific articles. Now you write for the common man." And there my argument was. My first article came up on April 1, by the way, 2020, and I gave three factors. I said because of these three factors, the mortality rate in India due to COVID will be much lower than the West, when you compare yourself in terms of numbers and all, and the severity will be low, because one, that we have been exposed to pathogens a lot. Our Indian subcontinent has so much of pathogens. We are, the microbial load around us is so very high, so much so that we have really a robust immune system there. The second was that our, and the HLA system I talked about, that plate, that formal plate which will present the pathogen to the immune system over there, is very diverse in the Indian population because of that pathogenic load. The more the pathogenic load, the more the diversity of the HLA system, that makes your and my life difficult for us to select a suitable donor from the population, for somebody needs an organ transplant or a bone marrow transplant. So the system is very polymorphic compared to the Western world, because there's too much of hygiene, and therefore the autoimmunity very high over there. And then of course third is the individual variation, which varies from one individual to the other. So these are the factors which will affect or influence the immunity there. Now you talked about the NGS. Yes, this is one of the remarkable developments in medicine, actually, or the lab based technologies, the next generation sequencing. Here we are able to really identify a gene uh, that differs by only a few amino acids over there, not even amino acids, a few sort of uh, epitopes. So the inborn errors of immunity, and the IEEs are very, very important here. They encompass a group of disorders with strong genetic component, and there is a prompt, and you need a prompt and accurate diagnosis of these disorders, which is very effective for their management point of view. So therefore, NGS has come up as a boon, which has significantly enhanced the diagnostic process by offering a comprehensive and a scalable approach for identifying genomic variations that are causal, that are of cause for those diseases over there. And coupled with that, we need the bioinformatics there. So bioinformatics and NGS together are going to be very important, particularly for the children, for diagnosis of primary immunodeficiencies. We have so far been only talking about secondary immunodeficiency when HIV came, and in the primary immunodeficiencies has taken a back seat, except for one or two hospitals in India, the Wadia Hospital in Mumbai, and we were in Monday. I do remember when the DG ICMR we said we need to develop at least establish at least 3 to 4 centers of excellence for primary immunodeficiencies, because these are very much common in the children there. And unless you diagnose them, correct diagnosis. And here the role of NGS comes very, very important there, not only for inborn errors of immunity, but the primary immunodeficiencies over autosomal or recessive modes of those diseases there. And then there is that X-linked gamma globulopathy, gamma globulopathy. These are all diseases which have actually been very usefully diagnosed through the introduction of next generation sequencing. Today, I think almost all centers around India also have uh, have the ability to do the NGS based diagnosis.
Very well elaborated, sir. And that point you raised about the nutrition, I want to elaborate on that. That the pre-pregnant vaccination, I mean the prenatal vaccination, and the pregnant woman vaccination, especially for flu, for DTaP, and the upcoming RSV vaccination for pregnant women, which has started in some other developed countries. They are very, very helpful. And then the concept of United Nations, the first 1,000 days, in which 270 days of pregnancy and 365 days for 2 years, the first 2 year, combining together is 1,000 days. And within 1,000 days, if you have a good hygiene, good nutrition, a good vaccination program, that the first 1,000 days are there, and especially adding in these 1,000 days, not giving sugar, not giving extra uh, fat and everything, not subjecting children to various carbohydrates, not giving them more screen time. It's a long way in preventing diseases in the long term. Dr. Gursaran, do you want to add anything
Here, I would
on
just
the?
want to give Dr. Narang just one data here. It's a very important point, because before there was good nutrition, we were talking about hygiene and the comprehensive vaccination there. There was still high mortality in infants, and there's a UK data. I just got this paper out. In 1900, for example, the UK infant mortality rate was 140 per thousand, and in 2000, that number has dropped to 7 per thousand. And I think the only change that has taken place is nutrition. So nutrition does
Yeah.
play a very, very important role.
Absolutely, because most of our hormones are formed by the proteins in the body and the by a good nutrition in our body. Dr. Gursan, do you want to add anything in that, especially for the pediatric immunological diseases? What kind of precautions do you take for the vaccination of such children? And especially here, you can even add that the immunocompromised patient, how do you take their vaccination forward, and whether they are good enough to receive all vaccines or special precaution with certain live attenuated vaccine or so on.
So, am I audible? I can't hear both of you properly. Am I audible to
Okay.
you?
You
You
are
are
Am I
audible.
audible,
audible?
and okay, what I was saying was
No, no,
that
I
in
got
the
you, but there is so much disturbance. I am asking, am I audible to all of?
Yeah,
yeah, you
you
are
are.
I
audible to
You are
us.
audible.
Okay, okay, okay. Yes, I got it. You asking about immunocompromised children. Should we vaccinate them? Should we not? Well, immunocompromised children or adults, all of them need to be vaccinated, just only because our concern is that it should not be a live vaccine, but all the vaccinations which are killed vaccines, they can be given to all the immunocompromised children, and the as the vaccination scheduled program, except that, like a mother has an HIV or the child has an HIV, then we need to do their CD4, CD8 and HIV viral load. And if the things are better, even in adults or even in children, then we can vaccinate them. But if the counts are very low, and then we can wait for the vaccination. So that's it. We need to be cautious in such patients, and they have to be given after checking the viral load, especially for the HIV,
Yeah,
because these days the HIV population, all of them are on treatment, and we have the families of HIV patients, the children, the adults, the mothers, and the fathers. So they are all going to live to a long time because of the medication, and the WHO has given free medications to all, and they're enjoying good longevity. So they're living almost a normal life. So they all need vaccinations, because most of them are now quite well settled in their immune system, because they are on proper
yeah.
treatment. So after doing their viral loads, CD4 counts, CD8 counts, depending upon that, we have to vaccinate them.
You're absolutely right. In fact, the immunocompromised patient need more vaccination, more precautionary measures, and all killed vaccine can be given. The live vaccine can also be given if they have a acceptable viral load as well as the CD4 and CD8 counts. So rather, if you are not able to give vaccination to such immunocompromised person, then giving vaccination to the inhabitant of the house, their parents, their children, and everybody in the house needs to take the vaccines which are going to cause the problem to them. And
Right.
especially, I must say, like when the patient is receiving treatment before is becoming immunocompromised, in that situation, if I give the vaccine to the house people for all diseases, including the live, provided the immunocompromised situation is not happening in uh, in around 3 to 4 weeks. So if I have a good 4 weeks margin of starting the therapy, then I will protect them from all diseases by immunizing the family members of the house. So that is very challenging thing, and good thought on that to come. Uh,
Actually, Dr. Narang, there is a question in the chat box exactly on that.
yeah.
एक राम जी अग्रवाल साहब हैं, उनका एक
Mm.
सवाल मैं पढ़ रहा हूँ। मैं 68 साल का हूँ, मुझे कौन कौन सी वैक्सीन लगवाना चाहिए? मेरी बीपी की दवाई मेरा बीबीपी दवाई से कंट्रोल में है, डायबिटीज नहीं है और कोई बीमारी भी नहीं है, बीएमआई मेरा 21 है। तो मैं तो कहूँगा बल्ले बल्ले है, तब तो सब
बिल्कुल
कुछ ठीक
बहुत
ठाक है।
And then
बीएमआई
apply the
बीएमआई 21।
21.
so
That's
if you
quite strange.
so
एक
I
वैक्सीन तो मैं जरूर कहूंगा जो लगाना चाहिए, वो है फ्लू वैक्सीन। ये फ्लू
absolutely
वैक्सीन आती क्वाड्री फ्लू फॉर्म में, इसमें 4 कंपोनेंट्स आते हैं। राम जी साहब, आप हर साल नियमित रूप से सितंबर के करीब ये वैक्सीन लगा लीजिए। ये वैक्सीन भी बदलती है हर साल, क्योंकि दो तीन कंपोनेंट तो सेम होते हैं, लेकिन एक दो जो हैं हर साल बदल जाते हैं। वो पता रहता है उनको कि 2025 के लिए क्या चाहिए, नहीं। और आपकी एज के लिए तो ये वैक्सीन लेना बहुत ही जरूरी
सर
सर
इनको
फर्स्ट ऑफ
शिंगल्स
ऑल
भी
आई
चाहिए.
सेल
He
है। हाँ,
needs shingles vaccination. He's 65 years of age and he needs
प्लस
both the
न्यूमोकोकल,
doses.
प्लस
And
या
he
बोथ डोजेज
also
न्यूमोकोकल.
needs a pneumococcal vaccination.
ये मैं
And
दूसरी कह रहा था कि न्यूमोकॉकल वैक्सीन भी आपको जरूर लेना चाहिए। दो आई
right,
वुड से
right.
ये दो तो है ही है, क्वाड्री फ्लू और न्यूमोकॉकल।
ओके
Pneumococcal
सर.
as well as shingles. And
यस.
if he has not been vaccinated for hepatitis B, or his titers are low, then he should be getting vaccinations for hepatitis B also. और टेटनस का डॉक्टर साहब हमारे यहाँ पे रिवाज ये है कि चोट लगेगी तो टेटनस का टीका लगा लो,
राइट।
क्योंकि अदरवाइज याद रहता नहीं. Actually, we just need TT or a Tdap after every 10 years. But either it really has to go into the system that we really need vaccinate our adults every 10 years according to the dates given. But what mostly it is there that it is पेशेंट्स की मन में ऐसा होता है, हालांकि जो टीटी की डोज वो लगवाते हैं उसका उस टाइम पे तो कोई फायदा है नहीं. बट ये होता है कि हाँ जी मैंने मेरी ये चोट आई थी, मैंने टेटनस का टीका लगवा लिया था. और मे बी इट्स जस्ट बिकम्स अ कोइंसिडेंस कि हाँ कभी ना कभी लाइफ में 5-10 साल के बाद एक टीका लग ही जाता है. सो दैट वे टेटनस गेट्स कवर्ड. बट दैट्स व्हाट
बट
द आंसर इज
फर्स्ट ऑफ ऑल
दैट.
आई वांट टू सैल्यूट राम जी के उनको अपने वैक्सीनेशन का ध्यान आया है, बिकॉज मोस्ट ऑफ द टाइम 50-60 प्लस के बाद तो अपने वैक्सीनेशन का ध्यान नहीं आता. उनको वंस इन 10 ईयर एक डी टैप लगना चाहिए, और फ्लू और न्यूमोकॉकल प्लस शिंगल वैक्सीन जरूरी है, और बाकी और कोई कोमॉर्बिडिटी पे करना चाहिए. और आपका बीएमआई बहुत अच्छा है, तो वी मस्ट से दैट यू आर कीपिंग गुड
नहीं, वो
हेल्थ एंड.
डायबिटीज भी नहीं है, बीपी भी नहीं है, तो हम तो ये कहेंगे राम जी साहब चलते रहिए, थोड़ा सा वॉक वॉक अपना चलते रहिए, 10,000 स्टेप्स रोज के, तो आप तो 100 साल तक ठीक ठाक से चलेंगे।
वेरी
सर
गुड
बीएमआई
सर.
इन्होंने कम कैलकुलेट ठीक से नहीं किया होगा.
हाँ, मेरे को लगता है बीएमआई कम बता रहे हैं।
21 नहीं हो सकता है.
नहीं हो सकता, यू आर राइट।
नहीं हो सकता if he is normal, if he doesn't have any chest diseases or COPD or something, so he cannot be a slim person. Such a
नहीं, हम
slim
कह रहे
सर
हैं
person.
कि
अभी
ऑन बिहाफ ऑफ द
सर
आईजेसीपी हम सभी ऑडियंस को कहेंगे कि और सवाल आने चाहिए। सिर्फ गुड
ये
इवनिंग से काम नहीं चलेगा, नमस्कार से नहीं काम चलेगा, और सवाल आए
सर
तो
अभी
प्लीज बी वेरी फ्री।
अभी सर डॉक्टर नरेंद्र जी, आपने यू टॉक्ड अबाउट ऑटो इम्यूनिटी अ लिटिल while ago, and I have a question for you. How does early immune dysregulation predisposes us to the allergic diseases such as asthma and atopic dermatitis? Do you think that uh, we are worrying about it too much, or has definite role in the immune dysregulation for
नहीं,
such diseases?
इम्यून डिसरेगुलेशन तो होता है, वो ज्यादा चाइल्डहुड में ही रहता है। और अगर हमने चाइल्डहुड में, जैसे आपने बताया और मैडम सिद्धू ने, टाइमली वैक्सीनेशन लेना बहुत जरूरी है। और क्योंकि वैक्सीनेशन और एक्सपोजर टू पैथोजेंस will make sure that your immune system grows to its fullest extent. What we need to have is develop memory cells to every possible pathogen हो there. हम थोड़ा सा ज़्यादा भी डरते हैं इससे, एस्थमा वगैरह में इतना प्रॉब्लम नहीं है, लेकिन अगर हमने ख्याल रखा हो, अपना वैक्सीनेशन टाइम पे लिया हो, और टू मच ऑफ, मैंने कहा ना, टू मच ऑफ हाइजीन, और ये तो कोविड के टाइम में पता चल गया वाकई। तो मैंने वो जो तीन फैक्टर, जो तीसरा मैं बता नहीं पाया था उस वक्त, तीसरा हमारा जो खाना होता है, हमारा जो फूड होता है। अब देखिए, जो हम खाना खाते हैं इंडिया में, उसमें मसाले बहुत होते हैं, उसमें हल्दी मसाले हर तरह के, दीज आर ऑल इम्यून स्टिमुलेंट्स। तो यू वुड से, मैं तो कई बार अपने जोक से अपने इंटरनेशनल फ्रेंड्स को कहता था, मेरी अगर वापसी करोगे तो मेरा तो पेयर्स पैचेस विल बी दैट बिग एक्चुअली compared to yours, because we have been exposed to all the pathogens that one very good way of exposing yourself to the pathogens and making sure that your immune system grows is the vaccination and vaccination on time. और आज के दिन तो और आपने शुरुआत ही किया था कि वैक्सीनेशन टाइमली होना चाहिए ये नहीं कि जो बर्थ में देना है वो उसको आप लेट दे रहे हो जो फर्स्ट मंथ में देना उसको भी लेट दे रहे हो नहीं तो वो इम्यून सिस्टम डेवलप नहीं करेगा तो ये सब चीजें अगर हम ध्यान से करेंगे तो हमारा ठीक तरह से चलेगा अब सवाल आ रहे हैं फटाफट उसमें
Good stimulation, sir. Uh, what are the latest update on the hematopoietic stem cell transplant and the gene therapy for certain immunological procedures and disorders? Uh,
yes this is
Dr.
a very
Narendra,
very
first you add, and then Dr.
yeah
Gursaran, you can also add on that.
या वेरी इंपॉर्टेंट पॉइंट बिकॉज ये मेरा मेजर फील्ड रहा है donor selection for patients who require bone marrow transplant but we don't use the word BMT we use the word hematopoietic stem cell transplantation because the hematopoietic cells stem cells can be taken from not only the bone marrow but from cord blood particularly for the children and even from the peripheral blood you can mobilize and we can also now through the other genetic tools can actually make stem cells in the lab as well. So हेमाटोपोइटिक स्टेम सेल ट्रांसप्लांट में प्रॉब्लम हमको आती थी कि डोनर क्या हो what we need is an HLA identical donor. Now, family may, because of the Mendelian segregation rule, generally, theoretically speaking, 25% of the children would be HLA identical, 25% children would be HLA unidentical, non-identical, and half the children will share one haplotype because we inherit one haplotype from the mom, maternal haplotype, one from the dad is the paternal haplotype. So we used to be dependent only on the HLA identical siblings for transplant. Then came a stage we were developing what are called the bone marrow registries. These are voluntary donors around the world. You know, the idea came in 1987, and I was at the time in Seattle at the Fred Hutchinson Center. And one of the young doctors came and said, why don't we create HLA the donor registers, and everybody laughed at him. "Oh, what are you talking? The system is so polymorphic. You need to make at least a million strong or a 2 million strong registry first to find out a donor for somebody." But then it became, and the Anthony Nolan registry in UK and all other registries. We have been also struggling to develop one national level registry in India, and I have had a number of meetings with the government of India. But we do have some um, private registries over there. So you can have a nearly matched, what we call 9 out of 10, or maybe 8 out of 10 matched, the donor over there, and that gives also a very good success rate. But that is even that is not sufficient because children with thalassemia, the family size is very small, and you are unable to find a donor over there. Our own practice in AIMS was that the total number of patients that come for bone marrow transplant at that time, only about one third, maybe 30% or so, were lucky enough to have an HLA identical sibling in the family, and we say, "Oh, it is a good news for you. Please go to the temple and sort of pray to the God that you found a donor." Because once you find a donor, at least the transplant can be done. And then, of course, the success rate has been improving year after year. Now we have come to a stage that we are also doing the haploidentical transplants from parents to the children over there. And even in the parents, there is so much of debate whether it should come from the father or the mother there. Immunologically speaking, mother could be better donor because the child has already developed tolerance to the non-inherited maternal haplotype. When the child was in the womb. But nothing to beat the HLA identical sibling transplants. But today we are also doing haplo in certain conditions there. For children against certain conditions, and I was a I was chairman of the group which made this ICMR guidelines for the cord blood transplantation, and people can go to the website of ICMR and look at those guidelines for cord blood transplant. Even cord blood, because the number of cells in the cord are not very high, but there are a couple of very important conditions in children that can be used, where the cord blood transplant can be used. So this is in brief the sort of message that we can give on hematopoietic stem cell
So
transplantation.
you're very right. So actually, directly, we are also practicing in Max as well, and actually directly at Rajiv Gandhi Hospital. So it's become a reality that actually directory is there, and especially working very good with the thalassemia children for getting the best donor.
No,
And
here I want to highlight one other point because the diversity of HLA in the population in India is much higher, as I elaborated a bit earlier, because of the microbial load that we have lived in. And number two, because of the population migrations that have taken place in the Indian subcontinent. I'll give you one example of HLA-A2. A2 is a very common gene. If I do HLA typing of 100 people in the hall, at least 35 to 40 of them would have HLA-A2. Now, A2 has been split into at least 400 subtypes, molecular subtypes, and all of them would have to be talked about as if the different subtype. One of the subtype is unique to India. We call it the novel subtype, HLA-O211. Now, O211 does not occur in the white race. So the registries that we have in the Western world, and if you have somebody in India who have HLA-A211, they are not going to find a donor for that individual. Therefore, the need, even the more need for Indians to have their own national level registry. This is the point
absolutely.
that this is the point that I've highlighted to
So
neither of the big
I
countries involved.
think before I go further, I want to know are there any question on the chat box or
There
are
is
there any
there's
particular
some
question? So I
your
think we
sound
should
is
take.
So
there's
you're
some
not
problem with
clearly
this.
audible.
There's some problem with the sound.
There's a
There
lot
is
of problem.
some scratching sound.
Yeah, the
Arpita,
voice
can
is
you
not
help us?
coming properly.
Can you
Yes,
help us? Dr. Narang sound when it comes, it is scratching.
Okay.
yeah, sir.
Yeah, lot of
Are
disturbance
there
is
any
coming.
questions in the chat box?
No, sir. There, I have put the questions which have come, and there are no other questions, sir.
So there is one question which I will also like to add on to that, but I know my
Sir,
panelists
can
will
you remove?
also.
Sir, can you remove the earphones and talk once? There is some disturbance.
So, what is the future of the personalized vaccinology in pediatric based on the immunological profile? So this is a
Yeah, I
question.
can read this question. Somebody is asking me, Dr. Mehra, considering your extensive work in immunogenetics, how do you foresee personalized vaccines? You know, the terminology personalized vaccines came up during COVID time. People thought that we make a personalized vaccine that might help actually, because everyone who was vaccinated was not actually benefited over there. But it is not that easy to tailor a vaccine to an individual's genetic makeup. One that I do my own HLA typing through the NGS based and all that, and then we needed data actually. I don't know which vaccine will work on me or somebody else. Personalized vaccine is not going to work. It was a thought. It was a more of an academic interest at that point of time. A vaccine is something that has to be universal, and both my colleagues over here are child specialists, and they will not believe in this because you want a universal vaccine. You don't want a personalized vaccine.
But in situations like the pneumococcal vaccine, uh, there has been attempt to develop vaccine pneumococcal according to the strains prevalent in a particular country. So we are working on that, but that A, it should cover most of the strains present in the world, then and there should be specific strains which are present in our continent, and that's the basis of making the flu vaccine every year, depending on the what kind of
Sir,
viruses are provided.
there is
रविंदर
lot of
आपकी आवाज ठीक नहीं आ रही थी।
आवाज ठीक नहीं आ रही बिल्कुल, पर
नहीं
मैंने
समझ
ये
नहीं आई।
क्वेश्चन देख लिया है।
नहीं
स्क्रीन पे आ गया है
गुरशरण,
कि
एक एक सवाल आपके लिए है डॉक्टर
हाँ जी,
गुरशरण
देर
सिद्धू।
इज
ये वो पूछ रहे हैं डॉक्टर सिद्धू फ्रॉम एन इंटरनल मेडिसिन perspective, how important is it to monitor and address the long term impact of pediatric immunization on adult health outcome?
Absolutely, sir. Like I said, pediatric vaccination is the building block. जैसे आपने काउंट कर लिए कि 1000 डेज, फर्स्ट 1000 डेज में आपने एक बिल्डिंग ब्लॉक बना दिया, तो everything has to come on those building blocks.
Yeah.
So adult vaccination is a new new baby in the block. पहले लोगों को इसके बारे में we were not understanding is too much. We were not very enthusiastic about it also a couple of years back. It is now that before and after COVID we are realizing अब हमने adult vaccination के अपने जैसे आप लोग pediatric vaccination के बनाते हो, हमने अपने cards भी बनाए हैं, and we are on the public platform also, and we whatsoever patients come to us, like all our patients who are on dialysis, we tell them particularly कि आपको pneumococcal vaccination लेनी है, आपको इन्फ्लुएंजा की वैक्सीनेशन लेनी है, उनके जो रेगुलर वायरल मार्कर्स हम हेपेटाइटिस बी सी एच आई वी रेगुलर कराते हैं, एंड इफ दे आर नॉट वैक्सीनेटेड और इफ इवन इफ दे वो वैक्सीनेटेड वी वांट टू उनके हम टाइटर्स कराते हैं और हम उनको वैक्सीनेट करते हैं. सो एवरीथिंग इज द एडल्ट वैक्सीनेशन इज बेस्ड ऑल ऑन द बिल्डिंग ब्लॉक्स of the pediatric vaccination, and
Absolutely.
it is now is very very imperative that as adults we need to vaccinate ourselves, which we were not realizing before. मैंने एक आइडिया आपसे ये लेना था एक्चुअली कि पेडियाट्रिक वैक्सीनेशन चार्ट होते हैं और हमने आजकल एडल्ट वैक्सीनेशन कार्ड्स बनाए हुए हैं अपने, एंड वी लाइक टू गो बाय दैट. पर मेरे को ये आइडिया आया था अभी बातें करते करते सुनते कि एडल्ट वैक्सीनेशन कार्ड को उसी पीडियाट्रिक वैक्सीनेशन कार्ड की एक्सटेंशन ही क्यों ना बनाया जाए.
वो बिल्कुल ठीक है। देखिए मैंने शुरू में कहा था, जैसे ये जो सवाल है ना, इज लाइक ए बैंक बैलेंस। आपने अगर
हाँ,
अपना बैंक बैलेंस बढ़ाना है तो
हाँ,
चाइल्डहुड में वैक्सीनेशन लेना बहुत जरूरी है। क्योंकि शुरुआत में ही डॉक्टर नारंग ने जब मुझसे सवाल किया था, मैंने कहा दो चीजें इम्यून सिस्टम में बहुत इंपॉर्टेंट होती हैं, एक तो स्पेसिफिसिटी, दूसरी मेमोरी।
हम्म,
मेमोरी जनरेट करना बहुत जरूरी है। दिस इज कॉल्ड इम्यूनोलॉजिकल मेमोरी। इम्यूनोलॉजिकल मेमोरी इज लाइक योर बैंक बैलेंस। आपके बॉडी में हर तरह के मेमोरी सेल्स हों जिन्होंने एक पॉइंट ऑफ टाइम पे वो पर्टिकुलर एंटीजन देखा है। द सेफेस्ट वे टू सी दैट वुड बी थ्रू वैक्सीनेशन देयर। So vaccination at the right time in the childhood will pay you in the long run.
आई थिंक दैट आई डोंट नो हाउ विल इट बी, क्योंकि हमने तो अलग अलग कार्ड्स होते हैं आजकल तो हॉस्पिटल्स में पीडियाट्रिक वैक्सीनेशन के अलग, तो हमने अपने एडल्ट वैक्सीनेशन के अलग बनाए हैं. बट आई वाज थिंकिंग इट प्रॉब्ली विल बी अ गुड आइडिया कि जस्ट टू गिव वन आईडी टू अ इंडिविजुअल, and then the adult vaccination should get superimposed on the same vaccination cards. It will show
I
us.
fully agree with you. It should be just a vaccination chart. इस एज में
Yeah.
ये लो, इस एज में ये लो, इस एज में आगे ये लो।
एब्सोल्युटली आई थिंक, एंड इट वुड बी अ जैसे बच्चे के वैक्सीनेशन कार्ड को उनके पेरेंट्स उनके ग्रैंड पेरेंट्स पढ़ेंगे, तो दिस विल आल्सो बी लाइक दे विल आल्सो अंडरस्टैंड, ओके बच्चे को इतनी एज तक लगती है भाई हमने तो लगवाई नहीं. आई थिंक दे विल आल्सो रियलाइज दैट वी आल्सो नीड टू गेट वैक्सीनेशन. सर एक चीज हमने वी डिड नॉट टच अपॉन इट, हमारे डॉग की जो menace है बहुत कॉमन है, डॉग्स हैव ईटन चिल्ड्रन, दे हैव गिवन लॉट ऑफ ट्रॉमा. और जो डॉग्स हैंडलर है, जहाँ तक रेबीज की वैक्सीनेशन का सवाल है, डॉग्स हैंडलर के लिए भी वो वैक्सीनेशन का एज ए प्रोफिलेक्सिस, वन और 1, 2 and 3 doses they are very important. And ultimately if there is a dog bite, then of course a booster vaccination is also important. I think those who are dog handlers and veterinarians, like we said, they it is very important for them, and especially the menace which is caused by the dogs presently everywhere in rural and urban areas. That is also a point I just wanted to touch upon that. And mm,
नहीं, वो
I
बहुत इंपॉर्टेंट पॉइंट है क्योंकि स्ट्रे डॉग्स बहुत ज़्यादा हैं
जी,
and I don't know the exact number. I think the number of people who require this vaccine, rabies vaccine, is in millions now. And I
millions,
think
yes,
something will have to be done, although the Supreme Court passes a law here and there and all that, nothing happens. You have street after street in India where there are stray dogs. And, those dogs who see somebody as a stranger coming for the first time. And the dog has a very important sense of smell. If that if that smell has not been seen by this dog earlier, it's going to bite you. So it's a problem, and we've seen videos and after videos where the dogs, the stray dogs, actually empower the older people, and some people have been killed even, by the
yeah.
dog, by the stray dog.
But it's not difficult actually. We just need to sterilize the dogs and we just need to vaccinate the dogs.
Yeah, but
Yes, sir.
And
I
you
think
know,
the enormity of the problem is very high.
it is possible. It is
Possible.
possible. और वो स्टरलाइजेशन या कैस्ट्रेशन ए मेल या फीमेल एक को कर दो, मेल्स को कर दो तो उनकी जो है ना एग्रेसिविटी वो बिल्कुल खत्म हो जाती है.
Yeah.
And I recently I went to Georgia and I saw a lot of stray dogs there and they were all like भौंक ही नहीं रहे हैं. They are just lying there and
Need
all
yeah.
of them they were having उनके वो लगा हुआ
yes.
था कान
So
पे वो.
we have to conclude, and the message I want to conclude, I'm very happy that the adult
सर
vaccination
आपकी आवाज नहीं आ रही.
डॉक्टर नारंग की प्रॉब्लम
आपकी
है कि आपकी आवाज
आपकी
साफ
आवाज
नहीं
नहीं आ
आती।
रही, समझ
अ,
नहीं आ रहा.
you
अभी भी
can
स्क्रैचिंग
conclude.
स्क्रैचिंग बहुत आती है। नहीं, मैं एक और पॉइंट रेज करना चाहता था जब हम डॉग्स की बात कर रहे थे। इवन पीपल हु हैव पेट डॉग्स एट होम, if they just bring them out for stroll and all, they leave them free like this. They must be chained.
Yes.
Many times they don't chain. The other thing is in India, all these people who have their own stray dog, there's no concept of lifting their poops.
Yeah.
My daughter lives in Chicago. She has a big dog, and she always takes her out, but has a sort of bag in her hand
Yeah,
all the
yeah,
time, poof,
yeah.
and she it's by law, and she says if I don't do it, there will be chalana log. यहाँ तो
Yes.
कुछ होता ही नहीं है. There's all kinds of shit lying all around and all that, you know. And the other point here, because children, people feed to these birds.
Yeah.
कबूतरों को जो दाना डालते हैं,
That's also very
और
bad.
बहुत खतरनाक है ये. और ये interstitial fibrous disease is so very common, and once it develops, because the pigeons, कबूतर जो होते हैं ये जब उड़ते हैं, इनके यहाँ से वो जो droplets आती हैं, and these are antigenic, and some
Yeah.
people are susceptible to that. So लोगों में ये भी एक मैसेज जाना चाहिए. Maybe Arpita, you can some point of time call some experts to talk about uh, this issue of feeding the birds. ये लोग समझते हैं कि मैंने बर्ड्स को खाना खिलाया, मैंने बड़ा दान पुण्य का काम किया, मेरा अगला जन्म जो है वो सुधर गया, लेकिन वो इसी जन्म में लोगों को बीमारियां देके जा रहे हैं.
करेक्ट सर, करेक्ट पॉइंट. सर, सिंस डॉक्टर नारंग का थोड़ा ऑडियो का इशू है, तो उन्होंने पहले लिखा था कि एडल्ट वैक्सीनेशन नीड्स टू बी प्रमोटेड. वैक्सीनेशन डज नॉट एंड इन चाइल्डहुड, इट शुड कंटिन्यू. एंड उनका सजेशन है कि वैक्सीनेशन चार्ट शुड बी फ्रॉम बर्थ टू 85 years old plus. So,
Yeah.
with that, sir's note, I would like to conclude our session for today. And thank you all. Thank you so much to all our distinguished speakers and our moderator for sharing their valuable insights today. It has been an incredibly enriching discussion on evolving landscape of pediatric immunology. So, on behalf of the entire IGCP group, I would like to express our sincere gratitude to Dr. Narang, Dr. Mehra, and Dr. Sidhu for their time, expertise, and thoughtful contribution. And a big thank you to all our attendees for being a part of this important conversation during this World Immunization Week. So, with this,
Thank
thank you
you.
once again and have a
Thank
wonderful
you
day.
very much. Thank you
A
very much.
great pleasure,
Thank
sir.
you. Thank
Dr. Nazim, Dr. Mehra, thank you so much.
you. Good. Thank you so much. Yeah.
Thank
Yeah.
you. Thank you so much.